Okay, so the next thing is recurrent loss. These are women who have had 2 or more miscarriages, and they have something going on that we don't really know what's going on most of the time. 40–50% we don't know what's going on, but it's resulting in loss after loss. It's usually genetic or reproductive, and women who have had sexually transmitted infections or recurrent induced abortions, they are at risk of having miscarriages, these recurrent miscarriages, and also women that are trying to get pregnant with in an advanced maternal age. The next thing we're going to talk about is incompetent cervix, and this is in this one's in chapter 9, and these all are resulting in bleeding during the first trimester. So I kind of organized it through trimesters. So the things I'm talking about right now are all bleeding and fetal loss during and reasons for fetal loss within that first trimester. So a woman with an incompetent cervix just means that her cervix is dilating and effacing prematurely, so before she's ready to go into labor. It's a structural defect. And in your ATI book, there is evidence that these women who have these incompetent cervixes, when they were fetuses, their mom was given I can't remember what it's called. It's a form of estrogen. I'm trying to look to see what it's called. Okay, their mothers were given diethylstilbestrol while they were in utero, and it's this form of estrogen. And then these girl babies were born with cervixes that were incompetent, and they had resulting in their fetal loss. It's just interesting what a woman ingests during pregnancy can result in all sorts of things that we really don't know about. Once they found this out, they stopped prescribing this form of estrogen to women. So women will just be unaware because there's no cramping, no uterine contractions. They just they present with these bulging membranes, meaning right there that cervical opening, which is dilated, their amniotic sac with their fetus is there, ready to be lost. They will probably have some sort of discharge or bleeding, possible rupture of membranes, not necessarily. And how we treat it is we're going to suture that cervix. So we're going to just suture that up tight. If there's a history of fetal loss due to incompetent cervix, they'll do it earlier, knowing that that is a risk. And then they're just going to remove the sutures at 36 weeks if there aren't any complications, and let that woman go into labor just naturally. So this is the McDonald cerclage that we do for the incompetent cervix, and you can see they tightly suture it up, allowing that cervix to stay closed until they're ready for the fetus to come out. The next one is ectopic pregnancy. This goes back to chapter 7. This is bleeding during pregnancy. And we talked about this a little bit when we were talking about the sexually transmitted infections in week 1. And this is where the embryo attaches to someplace other than in the uterus. 90% of the time it's within the fallopian tubes. So this is a picture, if you can see this, of an ectopic pregnancy. You see the uterus right here. These are the fallopian tubes. And then you see right here this ectopic pregnancy. So it's the leading cause of infertility due to the ruptured fallopian tube that can happen when the ectopic pregnancy is not found out in time. And they don't usually do, systematic if the woman doesn't go in before the 12th week, she'll probably have a ruptured fallopian tube. So getting in as early as possible is a good thing for women, so they can have the ultrasound and see if there is truly a fetus growing within the uterus. So the symptoms, which you can probably imagine due to this growing fallopian tube is the stabbing abdominal pain in the lower abdomen. Because remember, the uterus is still pretty low down within the pelvis at this point. You'll see these first trimester irregular bleeding, and really the telltale sign, you'll see it in test questions and things like that, is when you see referred shoulder pain due to the phrenic nerve irritation of the diaphragm because of the bleeding that's happening, you know that that is an ectopic pregnancy that they're referring to. You'll see these symptoms of hypovolemia, and here's a really great picture of an ectopic pregnancy that was removed. So the preferred method to resolve an ectopic pregnancy is giving methotrexate. Methotrexate is a cancer medication, and the reason why it works on an ectopic pregnancy, just like cancer, is because it targets rapidly dividing cells. And pregnancy and cancer are both rapidly dividing cells. So what they're going to do is they're going to monitor these HCG levels, and once the HCG levels are back to normal, then they know that the pregnancy is dissolved completely. There are side effects with methotrexate, just like with cancer drugs, nausea and vomiting, stomatitis, which is those mouth sores, and then dizziness. So surgical repair is either salpingostomy. Salping is the Latin word for fallopian tube. So they're either going to repair a non-ruptured fallopian tube, or they're going to remove a ruptured fallopian tube. So the next thing we're going to talk about will be bleeding in the second trimester. So molar pregnancies, or hyatiditiform moles, also known as gestational trophoblastic disease, will result in bleeding during the second trimester if you're trying to differentiate these. So I'm going to, let's see if I can make this a little bit bigger. I can't. So above it says placenta and umbilical cord. So what I do now is I kind of just give you a background in what a normal placenta and umbilical cord should look like, because these next problems in pregnancy have a lot to do with problems in implantation of the placenta and or the umbilical cord, or in improper growth of the placenta, something like that. So in a normal placenta, you should see these finger-like projections. They're called chorionic villi. Remember we did that chorionic villi sampling in the fetal well-baby assessments, fetal well-being assessments. And you can see right here that this is the maternal blood vessels, and it's just at the capillary level you see the transfer of nutrients and or oxygen or CO2. So if you see anything different than this kind of implantation, and the implantation should happen above here, right up at the top. Remember down here, this lower segment of the uterus softens. So if the implantation happens down here, there is a risk of bleeding, because this is not a structural, a strong structure for that placenta to attach to. It could result in the coming off of the uterus prematurely, which is one of the things we're going to talk about. So you can see right here where the chorion, where's my cursor? This is the chorion right here, and this is the amnion. Those are two parts of the ovum that form into the baby. Let's see, anything else I wanted to talk about? So these umbilical arteries, you can see these are massive arteries, which cause the massive bleeding when women have problems with postpartum and a uterine atony, where the uterus does not constrict postpartum. Okay, so with a molar pregnancy or hyatiditiform mole, what happens is there is not a fetus that is viable and something went wrong, and it's actually linked to choriocarcinoma, so a form of cancer. So you see that this is the the villi that I was talking about, the chorion villi, that should be part of the placenta, well, they over-proliferate, so they hyperproliferate, and they actually become fluid-filled, grape-like clusters. And one of the telltale signs of this is instead of just the bleeding, you see the vesicles actually coming out when they're with the blood. So the embryo does not develop beyond a primitive stage if there is an embryo, and it is associated with this choriocarcinoma, which is a very rapidly metastasizing malignancy. So women that have this are at high risk for developing cancer afterwards. So we need to follow them for a year, at least a year afterwards, to make sure that they don't have cancer. So a partial mole, there's a complete mole and a partial mole. So a partial mole, you'll see the very small development of a fetus that will never develop into a normal fetus. And what happens is there's a normal ovum, but it's fertilized somehow by 2 sperm. We know that only 1 sperm should be allowed to fertilize an egg. But in this, either this 2 sperm are allowed to fertilize, or it doesn't undergo meiosis, where you have that dividing of the cell. So it causes this strange sort of development within the chorion amnion. So it is, or a complete mole is where you see no fetus there, and that is caused from the fertilization of an egg that contains no genetic material. And you'll see that as a complete mole. So symptoms, and this is why we do that. That's what I was referring to when I was talking about measuring the uterus. When you see a hyatiditiform mole, because of those grape-like clusters that are fluid-filled, you'll see this excessively large uterus. So they'll be measuring way further along than they should be. And then you'll see, this is telltale sign, dark brown bleeding that resembles prune juice. If you ever see that, you know that is hyatiditiform mole, or these bright red blood that contains these vesicles that are coming out along with the blood. Of course, they'll be anemic because of the bleeding. And then they'll experience symptoms of preeclampsia that occur before 24 weeks. Normally, preeclampsia only occurs after 24 weeks. So if you see these symptoms previously to that, then we know that this is a sign of hyatiditiform mole. And then we'll see elevated elevated levels of HCG, which leads to hyperemesis. And then it's believed it's linked to uterine cancer. So we diagnose it by looking to see what is in the uterus, to look for those vesicles. We're going to remove it by D&C, and we're going to monitor those HCG levels to see if they go back to the normal level, and we know the pregnancy has been dissolved. Okay, that's it for this. So, but what I did want to mention on hyatiditiform mole is that we want, in the discharge teaching, we're going to teach them to take birth control, because they should not get pregnant before a year, because that we need to follow them very closely for 1 year to see if they don't develop cancer, because they are so highly at risk for developing cancer. Okay, the next one is placenta previa, and I just noticed we're at 13 minutes, so I'm going to stop this video. We're going to come back and start placenta previa. And this is all starting bleeding in the 3rd trimester. So if you're keeping track, hyatiditiform was the only bleeding in 2nd trimester. 3rd trimester starts with placenta previa, and the next things I'm going to talk about are bleeding in that 3rd trimester. So